perspectives. And so sorry, it's a bit blurry. When it comes to sleep, I think about this stuff. And I wish I could have a nap that good, right? How many of you wake up feeling like you've slept well? I think I used to.
Yeah. I hope I
Right. It's a challenging thing nowadays, I think. And then this is pretty funny. It's kind of anyone familiar with Battlestar Galactica? It's like a sci-fi series. But it seems like some of our pain is like a battle, right? Every time we, for some people, every time they get in bed, it's a battle to get good sleep because pain is bothersome throughout the night or things like that. So, any of you notice that when you've had aches and pains that it's more noticeable at night when you're trying to fall asleep?
Some of my neighbors.
Yeah, right. It's a pretty common thing. So anyway, hopefully our workshop tonight will address some of these things. And a quick introduction. I'm Craig Hadfield, and I'm a doctor of physical therapy. These letters mean Fellow of American Academy of Orthopedic Manual Therapy. It's a mouthful, so that's why they shorten it, right? And I've also earned a diploma in osteopathic physical therapy. And I don't mean to brag, but that's like the fellowship in orthopedic manual therapy is something that 2% of therapists earn. It's a highly sought after credential, and it's something that I have a passion for. I wanted to bring the most advanced type of treatments to Pinedale. There isn't any reason why a small town can't have the best types of physical therapy. So that's my reasoning for pursuing that, and I finished that about 5 years ago. Aside from that, I've been in Pinedale now for 10 years, but my wife has roots here, and so it feels like home for us, and it's been generally a very wonderful place for us, and being here is really great for some of my interests aside from my profession. I enjoy the outdoors. I'm not enjoying it as much as I should. Just from business and kids and all that stuff. But a little interesting thing about me is one of my hobbies is I grow bonsai trees. It's my zen thing. So it's a challenge here, but it's fun. I'm happy that Katie's here with me. We're looking forward to a good collaboration in terms of our businesses. For Proactive, we're making kind of a paradigm shift in our business model. We recognize that a lot of times when we deal with patients, that there's these health issues or wellness issues that are not getting addressed by the medical profession or by us. So there's this gap that exists where there's lifestyle issues that can really help people get more completely better for their issues. So we've got our occupational therapist, Emily Ray. She's pursuing a certification in lifestyle medicine through the American College of Lifestyle Medicine. She's kind of in the process of doing that. And kind of in partnership with that, we're going to be collaborating with Katie on certain things where she has some expertise. And so I'll let her introduce herself a little bit
Sure. And I'm gonna do a little bit more when I talk, because it fits with what I can say a little bit later, but, so, I was raised here forever, and was headed to medical school out of college, and then realized that my belief about wellness and health does not flow through a prescriptive, pharmaceutical solution. I just think the body is capable of healing itself, and we need to give it the space and the nutrition and the tools that it needs in order to do that. We need to get out of our own ways, in order to let our body heal itself. And so I detoured away from the idea of medical school, primarily because I did not want to be trained to prescribe. I wanted to be trained to heal. And it took a while to find the right avenue for me to do that. It took a cultural change, people ready to stop seeking a quick fix in a pill and ready to start changing behaviors. And then it took a certification program that matched with what I was wanting to do for my community. And that finally appeared after 20 years of searching through the Functional Diagnostic Nutrition Practitioner program, which is what my title there is. And yeah, so it took me a long time to get to the place where I now feel like I am empowered to serve my community and help people heal by changing lifestyle, by changing nutrition and what it is we're eating, and more importantly by supporting those changes. A lot of us know what to do, but the act of getting it done is challenging, and so that's part of what I do and what we're collaborating to do together is to help people not just know what has to change, but to test and to find out through functional testing what really is your body trying to tell you, and then how do we make that change permanent rather than this month it works and then next month it stops working. So.
Great. So this is kind of what we're discussing tonight. And I think this is a pretty good representation of how things can become a cycle, right? If you're in pain and that's affecting how you sleep, and that affects your overall wellness, and it can become this kind of downward cycle if you don't get something changed. I think about people I deal with that are like right after a surgery, and they're in so much pain they can't sleep, and then their whole day is just combobulated and it worsens their pain, and then they can't sleep even worse the next night, and so on. So it's kind of what the aim of our workshop tonight is, how do we address these issues? How do we break the cycle in a really good way? I think this next slide is something that is pretty important to me as a physical therapist, and I think that's where it matches so well with lifestyle medicine and functional medicine, is that my main focus as a therapist is to address the most underlying issue I can, so that there's a permanent change. So it makes sense, right? If you have a fish in the dirty water, yeah, you could probably medicate the fish so it could survive for some time, and that can do some good. But ultimately, it's better if we can clean the tank, right? And so I think that's, certainly, I have a lot of respect for medical professionals. There's certainly a place for certain medications and surgeries and things like that. I'm not putting anything down on them, but like I said, there is this gap of a lot of medicine is medicate the fish, it's treating the symptoms rather than addressing the most underlying issue. So hopefully, as we discuss things, we'll kind of come back to this often about how that relates to cleaning the tank, so to speak. And I would say this kind of concept is being used more and more by other professions that I'm aware of. So I think I think generally for our society, at least here in the United States, we're recognizing that medicine with all the prescriptions of addressing symptoms, is not really doing us the good it should. So, so how did, just kind of think about this, how does this concept apply to musculoskeletal pain? You know, we often can get by with taking some pain reliever, right? But are we really fixing the underlying problem? Or what about viscerosomatic pain? That's a big word. In terms of how our internal organs present pain to our body in certain circumstances, or how does this relate to headaches or even poor sleep? So we're going to try and get to the roots of that as best we can. So sorry it's not so clear on the display here, but this is kind of a big framework of the whole pain experience. And so I'll try and walk you through it a little bit, but let's start down here. This is where some type of stimulus occurs. Let's say you sprain your ankle, okay? That in turn leads to a stimulation of our nociceptors in our body. These are cells and nerve endings that are designed to detect a problem, right? And then that in turn triggers a response in our spinal cord, in this dorsal horn of the spine. And if you follow that up, that goes up to the brain, and it goes to the pain neural matrix, which is all these different parts of the brain that process pain. And I think the important thing there is to recognize that there's multiple places in our brain that we are detecting these pain responses. It's not just in one area. It's not just about the muscle or ligament, okay? And there's a part of the brain that's kind of like the relay center, and that starts sending these other information to other parts of the brain and back down through our body. And so let's just go back down here for a second. This happens very quick, by the way. When you have an injury, that information gets up to the brain. Very quickly, the brain triggers responses to send inflammatory factors and all these molecules and cells back to the injured area to begin the healing process, right? And then that actually can trigger more symptoms at times. And so that can be kind of its own little cycle. If you've ever had an injury, you realize that inflammation on its own, it can cause some pain, right? That has an important purpose, but, and then if you go back up to kind of the control center there, there's this corticolimbic response where it's all about the emotion of it, our behavioral responses to that stimulus, and then we get this autonomic reactivity. So autonomic system meaning like how our blood vessels dilate or constrict, our heart rate response, things like that. Autonomic is like the flight or fight kind of part of our body, right? So you can kind of see how some type of injury gets not only these molecular responses and chemical responses, but it affects our entire nervous system. And inflammation is a big part of that, and our immune response. And so I like this just because it's a good reminder that our bodies are complex. But you can kind of see that there's certain key parts to this where we can apply some intervention and change the outcomes, right? So maybe, we take some pain medication like acetaminophen, for example, that helps reduce the pain signaling to the brain, right? but it doesn't address where the tissue damage is, per se. Okay, so, initially we get this really fast pain response to an injury. Those are kind of sent through what's called the delta type of nerve fibers. And then over time, if that stimulus continued, it kind of switches to a different type of pain response that can become more chronic. So, anyway, any questions about that? It's kind of complex, but it all makes sense if you think about it collectively, right? And if you've ever had a significant injury, even a cut, you kind of experienced this. If you ever cut your finger on accident in the kitchen, you feel the pain, the sharpness of it, you get this response like, oh my goodness, I cut my finger, right? But then it still hurts for a while as the tissues heal, right? Okay, so when we look at down to the cellular level of what's happening, we got all these types of chemicals involved, and you can kind of see on the left here is the tissue injury that triggers these receptors to then trigger a response through the nervous system. I guess in a very foundational or fundamental way, the nervous system is probably the key system in our body because of how it communicates with everything else. So if your nervous system health is poor, you're going to have certain issues. And that can play into how sleep is affected, and certainly nutrition can affect your nervous system. And so Katie's going to talk about that a bit. Sometimes these receptors can become dysfunctional, and so the tissue, the injured area, can become hypersensitive to symptoms. And so there can be chronic pain in an area where there's not really any damage there anymore, but it's still operating like there is. This is happening. So this happens like in the skin by the cut, right? Okay. And then this is a bit of a diagram of what happens at the spinal cord or brain level. So basically when you first have, if you just focus on this part here, initially when these receptors get stimulated in the spinal cord, if they continue to receive that information through chemicals, then over time the body can create more of those receptors or more of the chemicals involved, so it becomes better at sending those pathways. And so then we can get what we call central sensitization, where the brain is perceiving pain in a very hypersensitive way. It's kind of like a good analogy I think of is like how you can get different sensitivities in a car alarm system, right? You can have the kind that will turn on if you break a window, right? Something pretty major happens, the car alarm goes off. Or you can have a system where the alarm goes off if somebody even gets close to your vehicle, right? So that's what can sometimes happen over time with the central nervous system. If it's exposed to this stimulus long enough, especially if there's like a feedback loop with how you're mentally or socially perceiving things, that can kind of worsen things as well. And over time it can become where your spinal cord and brain are becoming like super at detecting stimulus. It's like just hypersensitive there too. So something to keep in mind. And then this is a great visualization of how visceral pain occurs. And I think the thing I like about this is it makes you realize that, you know, we tend to think about organs like, oh, the stomach on its own, stomach acid is having an issue or something, but really, that's all very highly connected with our nervous system. And that is affected up into our brain subconsciously in a lot of ways. And so, you know, visceral pain can be a significant thing that people deal with. There are receptors in the internal organs for pain, and those we're just throwing all these up here. So there's nerve pathways that transmit pain to your spinal cord and brain through peripheral nerves, which are the nerves to the organ specifically, but then there's these splanchnic nerves. Say that 5 times fast. It's a funny word. And then there's, of course, one of our major visceral organs is our skin. The skin is the largest organ of the body, and we have so many receptors in our skin, right? So it's all connected to the nervous system. I wanted to throw this up here because this plays into headaches later. This is a diagram of how what we call trigger points in muscles are sometimes formed. So you can kind of ignore this for a minute. Up here, you can kind of see like the little reflex hammer being swung at the knee, right? Like testing a reflex, right? Like your therapist or doctor would do. That causes a small but quick change on the tendon length, and that sends a signal to the spinal cord, which in turn sends a signal back to the muscle to respond a certain way. Right? And so what happens sometimes is in muscle, so now where that little square is expanding out this way, our muscles that control our limbs have this muscle spindle in them. There's several of them in each muscle group. And that muscle spindle is kind of like its own tiny little brain. And it communicates with the spinal cord in that way. So if there's damage to this muscle spindle, then it can send misinformation to the spinal cord and tell the muscle to stay tight. It won't relax. So that's an issue with certain things like tension headaches or other injuries to the neck or any muscle in the body, really. And so, again, just kind of demonstrating that even at the smallest muscular layer level, the nervous system is really key and can be an important target for causing some important change. So, a lot of times this can happen from an actual physical injury, like that part of the muscle was torn with a forceful event. But there's also what we call nutrient deprivation injury, where that muscle spindle is deprived of oxygen or other key nutrients, so it malfunctions basically. It's kind of like the motor in your car seizing. It just didn't get enough gasoline, and so it can't really do its job anymore. So then when we stress that area again, it triggers symptoms again. So then it can become a chronic issue. So who knows the word fibromyalgia? Ever heard that one? So this is pretty recent research. It used to be kind of a diagnosis by elimination, like nothing else is causing the pain, so it must be fibromyalgia. Right? Well, they know a bit more about it now, which is good. It's technically diagnosed by having pain in 4 out of 5 areas of the body for more than 3 months. And there's often psychological components to this. So people that have depression and anxiety. And then there's a whole bunch of other pain contributors to this kind of thing. And so, chronic fatigue, sleep disturbances, hint, hint. And so, there's, like we were talking about earlier, there's often some like peripheral tissue issues, like out towards the muscles and skin and tendons and ligaments, but then there's also this central nervous system issue too, where there's, when they've tested people with true fibromyalgia, they have less serotonin and norepinephrine in the spinal cord, which is really interesting. And then there's this dysregulation of dopamine that occurs. So, and we talked about how there's all these chemicals that are involved with sending pain signals. And so for people with fibromyalgia, they have more of those chemicals already available in the body. And then there's this increased sensitivity of the nervous system that we talked about too. So fibromyalgia is kind of an interesting one. It doesn't really respond, and this is what I see in the clinic, is people come in at, like, I've been diagnosed with fibromyalgia, and ibuprofen doesn't help. Acetaminophen doesn't help. It might help a slight amount, right? And so they really don't know much to do about it. And so there's some really interesting treatments we can do with physical therapy, and certainly, like we mentioned, with fatigue and sleep disturbances, lifestyle medicine issues can be a key thing for them. So, any questions up to that point? So the pain experience is a whole system experience, but a lot of it is nervous system related, right? And immune function related. So, and those are all things that are affected by nutrition and sleep. And so, we're going to switch gears and talk about headaches. How many of you have dealt with a headache before? Yeah. Would any, like, would you say that your headache has been like a migraine type headache? If you've been to an emergency room with a headache, you've probably had a migraine. That's probably one of the key things I ask for. Like, you know, there's some people that will bear it out and not go to the emergency room, but if you've had a true migraine, you've probably been to the emergency room. But there's 14 different types of headaches that have been classified. So wrap your brain around that. But there's kind of some key ones. Some of these are pretty rare. Migraine, so these are primary headaches where the headache is in and of itself the problem. The others are kind of secondary headaches. So migraine, we'll talk about that one. Tension type headache, we'll talk about that one. Those are kind of the more common ones. Trigeminal autonomic cephalalgia. This is like where the trigeminal nerve has a malfunction of its own, which is extremely painful. I don't wish that on anyone. And then we'll probably talk about headache from injury to the head or neck. And then there's headaches related to substances and infection. Those are kind of interesting to think about in terms of lifestyle medicine, overall wellness. So yeah, that's kind of a good overview of all the different types of headaches. So, any questions about any of those?
I knew there were 14 kinds of headaches.
Yeah. So yeah, if you go to a largely populated area, like let's say the Dallas metro area, you can probably find a headache specialist. It's usually a neurologist, because there's so much of this that is neurology related. But and but there's some really cool things we can identify that helps us kind of diagnose what they are. So a migraine this is pretty shocking. I didn't even realize this. The third most prevalent disorder in the world is migraine headache. And it's, as best they know now from more recent research, it is truly a kind of a nervous system dysfunction. What triggers that is kind of a whole other issue, but that's primarily where it lies. They used to think it was a vascular issue because a lot of people would say it's the throbbing they get, or things like that, but it's most likely a neurological thing. There is usually a family tendency to it. You might have parents or grandparents that have had migraines, that kind of thing, or siblings. And this is one of the key things that identifies a true migraine is the side that you feel the headache can change during one episode of a headache. Which is kind of interesting. Like you wake up and you're like, oh, I'm feeling a headache on my left side, and then before that headache goes away, it's shifted over to the other side. So that's something that we can use to kind of weed out what kind of headache it is. And so then some of these terms you might have heard. Have you ever heard of a migraine with an aura, or aura in general? So we'll get to what the aura is, but a headache, a migraine headache without the aura is kind of what you see here. It's usually on one side of the head, usually has like a pulsating quality. Like I said, it could shift to one other side during one episode. It's usually made worse by usual physical activities, which is sometimes concerning. And usually they're moderate to severe. So, and you get some nauseousness or really sensitive to light or sounds, right? Anyone have a headache like that before, where you just couldn't stand the bright light or loud sounds were really bothersome? So that's kind of a migraine without the aura. So the aura is like these strange other symptoms that can occur before or during the headache. Sometimes, sometimes when people will get like these speckly sensations in their eyes, they might hear different sounds that are really there. It's kind of an interesting thing. They can usually say, like, when I have a migraine, I definitely notice like these like sparkly things in my vision before it came on. So that's kind of typical. So it's kind of interesting. Some people get that. Some people get these aura without getting a headache, which is kind of interesting. I don't know how that happens, but they get those strange sensations. And so sometimes it'll be diagnosed with migraine with aura. So that's what that means. And usually when they have a headache like this, afterwards, they get these other symptoms, like they suddenly become super active or very sedentary. They go through depression or cravings of certain foods. It's kind of interesting. So as you can imagine, how our nervous system works, all of those different parts of the brain being affected by a headache, right? And then sometimes if you ever go to a physician and you get diagnosed with a migraine, the little diagnostic code that you'll see on your referral will say, with or without migrainosis. And that just means it's lasting a long time. So, and any of these types of headaches can become chronic, which is unfortunate. Something that's interesting is these type of headaches that persist, there's a pretty high correlation with problems of the neck in these cases. So if you've ever had a headache that was severe, that lasted a long time, there's a good possibility your neck is having some problem in the joints. There's either some stiffness not allowing them to move well, or some inflammation or something like that. So that was kind of migraines. Does anyone you know have migraines regularly? Yeah, I used to get them when I was like an adolescent, and as best I can tell, kind of in retrospect, looking at my habits and stuff then, I was often playing soccer for long periods of time, and probably not consuming enough fluids, so I was probably getting neural fatigue, and that was triggering the migraines. But I would go through a day or two where things were really sensitive to light. I'd basically close myself in the room in dark for a day or two. So, but people with true migraines, it's really unfortunate. So I'm always happy when I can help someone with migraines even get less frequent headaches. They may never go away completely, but if we can get them to go less frequent, that's great. So there's the next primary type of headache is a tension type headache, and you might have heard of this as kind of like the stress headache. Anyone ever feel like they've had one of those? Yeah, this is really common. Like you can see here, up to 78% of people have had one of these in their lifetime. Right? So it's a pretty big thing. You think about if 78% of people are getting a headache at some point and they're missing work, then that's a huge socioeconomic economic impact there. But sometimes this is difficult to diagnose because they can suffer from multiple types of headaches. So you might have a tension type headache overlaying a migraine or another type of headache. And so they used to think that this was completely stress related. That's why it used to be called a stress headache. But now they've identified some other things that make them believe there's more of like an underlying actual neurological issue that makes people more prone to these. And so I would say that these are probably, for me in physical therapy, I see these and probably cervicogenic type of headaches more often. We'll talk about that one in a minute. So these types of headaches can be episodic or chronic, and there's often this, if it's chronic, it's probably more related to the central nervous system issues that we kind of mentioned early on, how the body's adapting in a bad way to promote these pain pathways that perpetuate the headache. If they're more episodic, like they only happen every so often, like a couple times a year, it's probably more peripheral. Really. Like let's say you stayed up late getting ready to present at a library and you get a headache, that may be more of a peripheral injury kind of issue. So this is a little different compared to a migraine. Usually this is both sides of the head get a headache. It's usually both sides in some form. They're usually more mild to moderate, and usually activity doesn't make these worse, which is nice. In fact, we'll see later that some of the treatment actually that helps is exercise. And you can generally reproduce the symptoms by pressing into certain muscle groups. So the facial muscles, like a lot of times people will have like this temporal muscle pain, jaw pain, and then usually the back of the neck, throughout the whole neck is usually very tender, tight. There's a very precise way we can measure how sensitive the muscles are. It's not very practical, but it can help with diagnosis. So that's kind of, you kind of remember what the migraine was. The migraine was one-sided, it can shift sides, whereas this is both sides, and it kind of stays that way. So, nothing to be too alarmed about this. It's not like you're having a huge issue, but if they become chronic, they can be quite bothersome. And then the third type I see often in the therapy clinic is cervicogenic headache. Cervicogenic just means anything arising from the neck And so that could be the discs in the neck, the muscles, the joints, and so, and this is kind of interesting. This study showed that there tends to be this this connection with the trigeminal nerve. I'll show you what that means in a minute, and the neck. And so this is a really interesting thing that happens with our body. So to kind of demonstrate what this means, so up here, this ganglion here, those are where the nerves from inside the cranium and the trigeminal nerve pass through there, and then they come and converge down into this spinal nucleus. And so then these nerves from the neck also go through this area. So there's this convergence of nerves very close to each other where the brain processes those signals. And so what we think is that, let's say for example, there's a joint in your neck that is painful and stiff, your brain's confusing that with something inside your brain, inside the cranium. So you get this sensation, oh, I have a headache, but it's actually really coming from the neck. And so people will be kind of surprised that after we treat the neck, everything gets quite a bit better. So, this headache is usually found on one side and usually does not change sides. Usually it's just one-sided. Sometimes I'll see where people have it both sides, kind of like a double cervicogenic headache, but it's usually one-sided. More common in women. And the key things here are when we press on certain structures, it provokes the symptoms, and it's usually associated with a very limited range of motion in the neck. So usually these are things that happen after traumatic injury, like they've been in a car accident, or they sat and watched TV with their neck turned the same way for hours, something like that.
Never thought of that as traumatic injury, but okay.
Yeah, whoever's been watch some Netflix may have these. Okay, and there can be other symptoms along with it. But, so that's kind of an overview of the most common headaches, and you can see that depending on what headache you have, there's often a neurological part to it. Sometimes there's some actual joint or muscle dysfunctions happening, things like that. And so, from a physical therapy standpoint, we can do quite a bit to address the underlying issue. You know, if you were to take ibuprofen and other headache pain medications, yeah, you'll probably get some relief, but it probably continue on in some way over time. In terms of how we diagnose these in physical therapy, we look at some of those things we mentioned. We check the range of motion. There's a flexion rotation test, which is we really flex the head a lot when we turn the head, and we see how much it can turn each way. If there's some asymmetry with that, then that's diagnostic. How sensitive things are, and the forward head posture is actually an important thing for headaches. So, you know, in our day and age where we spend a lot of time on computers, our phones, there has been an uptick in headaches related to that over the last couple decades. But so we can measure the forward head position with that. And then we check how well the joints are moving throughout the spine, and we look for those trigger points like we talked about that can form sometimes with injury or nutrient deprivation. And then we always try and take into account lifestyle issues like sleep, nutrition, psychological things like depression, anxiety, and all those things, so that we can get a whole picture of what's happening. Unfortunately, for one session or episode of care. We're kind of limited to what we can do, but we try and guide people as best we can on making changes that will help for the long run. So for some treatments that can be helpful in addressing those underlying issues, kind of at the root of that. There's a technique called dry needling. Have you heard of that before? Any of you had dry needling? Yeah. So it's a relatively new treatment. It's based on Western medicine. It has some similarities to acupuncture, but we do not get Oriental medicine training for it. It's from research on muscle pain syndromes, and so we've adapted to using these smaller needles and things. But so there's some good research that shows that dry needling can be effective for headaches, and the reason for that is the dry needling can help stimulate the body do some things it's having a hard time doing. It helps increase blood flow to the area, which can help kind of flush out some of the buildup of chemicals that are causing issues or inflammation. It has an effect on the body releasing its own natural pain relievers, which can be helpful, and it can improve nerve function and stimulate some improved immune function in the area. So there's several things that, yes, you get some pain relief from it, but ultimately it's promoting some actual change, which is good. And then I talked about aerobic exercise. That has been shown to be beneficial. You can kind of geek out on the statistical stuff if you want to, but basically if you're getting migraines, exercise is important. That's pretty consistent with any type of nerve issue, is you want to increase blood flow to the nerve so that it functions more normally. There's some really important things with diabetes that way too. But, spinal manipulation, so that's something that I've become specialized in through my fellowship program, popping joints in the spine. That's effective because of how it affects our nervous system. The popping sound is nice to hear, but that's not necessarily what's causing the benefit. It's more of how our nervous system reacts to that stimulus. So anyway, medications can be helpful too, but medication or manipulation was actually better over time. That's pretty true, I think, for most medications. They have an initial positive effect, but over time they kind of lose their effectiveness. Of course, there's some exceptions to that. I mean, there's certain conditions you just have to take the medication your whole life, but for headache, that's something. So physical therapy for tension, headaches, again, the dry needling can be effective, and doing some work on the tense muscles, of course, in some way is kind of the key thing. So there's lots of different ways we do that, but you can see here this soft tissue interventions, that's like massage or trigger point release techniques or things like that. They were superior to doing nothing. So that's good. But, again, physical exercise, physical activity is important. And by the way, more and more studies are showing that physical activity is superior than antidepressants and anti-anxiety medications. So it kind of makes sense, over time as our society has become more sedentary, we're losing that physical exertion regularly, that reintroducing that seems helpful. Right. This is just a quick, this is from one of the, so for cervicogenic headaches, manipulating the spine, especially the upper cervical area, popping the joints there is really effective. And then this shows you kind of what dry needling treatment can look like. They're targeting just that right side, specific structures there. And and then even popping the upper back joints can be quite effective because of how it affects our nervous system. So that's often a combination of treatments I do for headaches. And of course, if there's areas of concern, like they have weakness in certain muscles or whatever, we'll do exercises too. But, so this is from a study that I helped collect data for. And you can kind of see here the red line group, those are people that received kind of like our standard treatments, which are like mobilizing the joints in a more gentle, repetitive way, and certain exercises. But then comparing that group to this blue line group, which is the treatment I just showed, having the neck and back popped and then dry needling, you can see that the frequency of headaches is quite a bit different. Even 3 months later, the disability of how much they think the neck headaches are affecting their livelihood, and then this is the intensity of the headaches. So you can see that those types of interventions are more effective than kind of the common old school stuff that we used to do. So let's take a small break and then we'll come back and talk about some sleep stuff.
Awesome. Let me stop the video over here.